Dr. Havens is also the highly appreciated pharmacist by both patients and providers. So they are experts at what they do and also expert teachers. So I'm really excited to hear what you have to teach us today. So they'll come around and get our orders for dinner too. Y'all will just go ahead and, get started.
Perfect. So we're excited to be here and to talk about PrEP. I know it's a diverse audience, and I'll point one thing that we have here today is we have Ann Fitzgerald is in the back room, and she's from the Nebraska AIDS Education Training Center, and at the end she'll hand out some evals that are really more just for documentation for our training center purposes. But we'll get started, and we'll try to make this interactive, so if you have questions as we go, feel free to interrupt. We'll go from there. All right. So,
pointed at the laptop.
Okay. There we go. So that's just our disclosure for CME. So we're going to talk a little bit about, give a brief overview of PrEP. I know some of you probably are already prescribing and know a lot about PrEP, so we'll try to be brief with that. We're going to talk about some challenges with PrEP management and some of the ways that we can implement PrEP throughout the community, and then some opportunities for getting more patients access to PrEP. So we'll start with some introductions. I just have a few questions for the audience. The first is, how many of you, just by a show of hands, were familiar with PrEP before today's session? So most of you. Okay. How many of you have referred patients for PrEP? Okay. And how many of you have prescribed PrEP? So just a few. Good. So I'm glad to see that some of you have no experience, and hopefully we can walk away with some new tools for how to provide PrEP. Okay, so first we'll start with a very basic, what is PrEP? It's been around for a few years, but still important to review this basic one. So it's pre-exposure prophylaxis, and it's a strategy of administering antiretrovirals before the exposure to people who are HIV uninfected in order to prevent HIV. And the way I like to think of this is very similar to antimalarials before patients travel to an endemic country, or to contraceptives before to prevent pregnancy. And we have one medication now approved today for HIV pre-exposure prophylaxis, which is tenofovir or emtricitabine, which are combined together as a brand name Truvada. And that's the only one that is FDA approved. There are many others that you may hear about that are still in clinical trials, but this is the only one that's currently around. What's important to know about it is that it's also the most commonly prescribed backbone of any antiretroviral therapy for patients who have HIV. So it's a partial treatment regimen. And one of the interesting things about PrEP is that just figuring out how it came about. So when they were studying it, it really came from post-exposure prophylaxis. So we learned that it's more effective to prevent HIV the earlier you give the post-exposure prophylaxis from the time of the exposure, and then they felt, well, what if we give it before the exposure, and found it was very effective. So PrEP is very, very effective. One question that we get asked is, why do we even need PrEP? For years and years and years, we've known exactly how HIV is transmitted and how to prevent the transmission. We know that condoms are effective, but despite this, every year that despite the fact that we've known for so long how to prevent it, we haven't seen a dent in the numbers of new infections. Okay, so we're still seeing too many infections each year in this country and worldwide. The other key thing about PrEP is, I don't know, have any of you heard about the End the HIV Epidemic, or the HIV Elimination Plan that was announced by President Trump during the State of the Union, and has really gained some traction and getting some small amounts of funding in certain areas for HIV prevention. And PrEP is actually one of the key components of the HIV Elimination Plan. And so it really is an effective tool to end the epidemic and end new infections in this country. Now, I wanted to share my personal experience for why we're here today, even though I hate public speaking, and why do we want to teach other people about PrEP. And it's really because every time we see a new patient in our clinic with a new infection, and they tell us that they knew that they were at risk for HIV and tried to get access to PrEP, but couldn't find a provider or asked their primary care provider, but their provider told them that they didn't know how to prescribe PrEP or didn't feel comfortable prescribing PrEP, my heart kind of sinks a little bit and I say, we need to get out there and find more people to prescribe PrEP. So that's the reason I think is most important. Okay. So then the question becomes, we have PrEP, it's FDA approved, but how effective is it? Anyone want to venture a guess when patients are asking how effective PrEP is?
90?
90%. So you guys have heard, I think the campaigns have been effective, and that's true. When used appropriately, it's 90% effective, okay? So it's been studied in many different patient populations, in men who have sex with men, in heterosexual transmission, in IV drug use, in transgender individuals, and the efficacy rates have really varied in all the different studies. You can see some of the studies have even failed in terms of their efficacy, and it's directly related to adherence. And so if taken as prescribed, it's 90% effective. But that's where it comes in, and that's where it comes in for us providers to really educate patients about how to take it, how they can become adherent. And that's where we lean on our pharmacists a lot, because they really have the tools to help patients, educate patients about adherence, and from there. Okay. So then we know that PrEP is around, it's FDA approved, it's effective. Which of your patients should be considered for PrEP? And there's a whole list of criteria, the CDC. We've just highlighted some of the more common and important indications for PrEP, but anyone who's at risk for HIV is a candidate for PrEP. So that includes anyone with IV drug use, with who's engaging in condomless sex, who has multiple partners, anyone with a history of an STI. And so that's one way that we're trying to engage places like Douglas County. Anyone who gets diagnosed with a sexually transmitted infection is also at risk for HIV. We've seen a lot of patients with new HIV infections come to our clinic, and 2 years ago or just 6 months ago they were in the ER or somewhere with an STI, and that would have been an opportunity to offer PrEP. Previous need for post-exposure prophylaxis means they're probably a candidate for pre-exposure prophylaxis, illicit drug use, commercial sex work. And then I have probably what the most common indication that we see patients being prescribed PrEP for, but it's a little more nuanced, and so I want to talk about it in a little while, but it's anyone who's having sex with somebody who has a known HIV infection. Yeah?
So how do you define multiple partners?
Good question. So you can define
More
it
than one.
so more than one partner, either sequentially or at a given time. Yeah.
When we
Questions
say
about that?
history of previous STI, because that just widened my demographic.
Yeah, and
Vastly right there.
so I think that's a good question, and it brings up the question of not everyone is at, or risks change. And so somebody who may be at risk 3 months ago may have changed their practice or behaviors and not be at risk now. And so I think that depends on if the patient is still engaged in
So my
high-risk practice.
30-something-year-old married woman who maybe had one when she was 21, you
Right.
don't have to do it. Okay.
No. But if they have ongoing
Yeah.
infections, or at the time that you're seeing them for their sexually transmitted infection, that may be an opportunity to at least discuss PrEP. Yeah. Okay. Then I'm going to hand it over to Josh, and he'll talk a little bit about the nuts and bolts of the management.
All right, so I feel like you guys need this screen more than anybody here. Well, thanks for having us here, and especially me. I think just before I get going here, when I came to the clinic, we had two PrEP patients. That was 4 or 5 years ago. And since then, I don't know what we have now, 150, close to 200, something like that. And I'm to the point where I got to cut it off because it's too much for us to handle. So I'm happy to hear that some of you are already doing it, and the more the better. The guidelines that are out there, there's several of them. We pretty much follow the CDC guidelines. This is just a table format of those. I will say that there are some differences in this table versus what the guidelines say, and that depends mostly on the risk factor and what people or what the patient is reporting to you. But in general, it's an HIV test every single visit, so it's quarterly visits. We also do a baseline chemistry panel and then follow up right after, like 3 months after they start, and then twice annually after that. But it's really important to rule out Hep B because both medicines will treat hepatitis B. And if you treat it without knowing, it causes acute liver flare, and that's something we certainly don't want to happen if they were to go off of the medicine. Hep C is important to screen. I think we all recognize that in certain populations, like IV drug use and men who have sex with men are another population that would be important to screen as well. And then pregnancy is certainly as needed, and most women probably do that on their own, but certainly we offer it. STIs is a different animal though, and we see quite a bit of STIs. It's upwards of 40, 45, sometimes 50%, depending on the person and their risk factors. I think the most important thing with STIs is screening appropriately, and that's not always done. You really have to nail down where people are or how they're sexually active to screen the right site. And about 40 to 50% of people that have STIs that are asymptomatic are in the rectum or in the throat that we see anyway. So they don't have symptoms, and that's probably why our rates are a little bit higher around here if we're not screening appropriately. So it's important to do that. But the CDC guidelines will say every 6 months. I think some people probably need that every 3, depending on their practices. And so the recent data would support that as well. And feel free to throw out questions as we go here. This is just a testing diagram that shows the different generations of tests. We use a 4th generation point of care test. The difference is just the detection window and when you can catch these folks. You can see, and I'll show you the test here in a minute on the next slide, but we use an allele determinant. It's a point of care. It just requires 50 microliters of blood. It takes 20 minutes to run. So you can tell people with great accuracy for the most part that they're either positive or negative. And that's really a nice feeling instead of waiting for the next day or 2 days for the test to come back. But it's pretty self-explanatory there. This is our test, and you can see this is our control box. The blood flows up. You guys might remember there's a P24 antigen that shows up really early, and you can see acute infection right here in an example where you would catch somebody within that detection window before the antibody shows up. But most folks that are detected, you're just going to see an antibody. I will say that there are some false positives that show up with this test, and so that's one of the downsides. We're seeing more of that as we screen people more. But certainly, this is only a screening and not a confirmatory test, so you gotta make sure you follow the proper steps there. So probably one of the most common questions that I get with PrEP is what's the cost? And if you look at this slide, you can see the drug cost is $2,400 a month. That's a wholesale acquisition cost, so it doesn't factor in insurance and all that sort of thing. The cost for the labs is an annual basis, about $4,000. This is based on our cost at Nebraska Medicine. And I'll show you, for the most part, we can get this down to zero. And it equals out to about $38,000 if you didn't have anything, right, from an uninsured perspective. But you can get it down to zero more often than not. And if you're in a private practice or something like that, that might be a little bit harder, but there's ways to get around that. So those are just random costs here. So if you total them up, you got your annual lab costs, your annual drug costs, and what it would cost in general. So sorry, it's not 38, it's 32,000. But you can get rid of the drug costs entirely. Like you can wipe it out to zero with utilization of programs that Gilead provides, but also there's a couple. You might be familiar with. There's PAN Foundation, PATH Foundation. These grant foundations that provide secondary assistance for folks that don't have insurance or those that do have insurance but can't pay for their co-pays and maybe they've utilized all their co-pay card that's available. So, oh yeah, go ahead.
Is it not covered under insurance?
So it is covered, and I would say my experience has been that it's very rarely not covered.
Seems like a stupid thing.
Yeah. The thing we get that's more of a hassle than anything is a prior auth for what is this being used for, and they simply ask a question of, are you using this for HIV treatment or PrEP? And it's a dumb thing that it's managed care, but it is what it is. Yeah.
Sorry, this is kind of dumb but practical. Just like in our clinic, we don't have like social work and people that
Yeah.
navigate these
Yeah.
grant stuff? Like, could we go online and print out some handouts?
Yes.
For this to be like, here's where you
Yeah.
go, and because I think that's the biggest issue that I've.
It's funny you mentioned that because I was looking at these slides before, like right before I came here, and I thought, man, I should have put those websites in there. But you can do the patient assistance, like even from an uninsured perspective, you can do the patient assistance online without having to print out a paper, fax it in, do all that sort of thing. So they've made it a lot easier from that perspective. All of the copay cards can be done within 2 minutes. I mean, it's really easy.
And patients can do it themselves.
Yes, yeah, and we encourage them to take that on if they can. I mean, anytime you can shift the responsibility back to the patient, I think that's a positive thing for their healthcare. But the luxury we have is we have one person that handles it all for us, which is very, very nice, and not everybody has that, and we understand that. But it is quick. So once you understand the process, it's not so bad.
It's just Gilead.com.
So it's GileadCopay.com, and maybe I can send
the link.
Yeah, I can send a link for you actually, if that would be best. And that's where you can get the copay card, but also the patient assistance for an uninsured person as well. So I think I have something here at the bottom. The lab cost is really what you got to focus on, and if they're uninsured, a lot of times we can get that bitten off by charitable care or do a sliding scale fee or something like that. At our facility, it's not like that everywhere, but certainly you could work out a plan for those folks. It's all about expectations for me, and if we lay it out for them right away so they understand that, that's probably the most important thing. But one thing we do see is this issue of persistence, and I don't want to get into it, but people go on and off PrEP all the time, and cost is certainly a big factor in that, I feel like, and so if we can minimize that, that's really nice. So the person that also does the drug side of things also takes care of that on the front end, so we can kind of see what their expectations might be.
Real quick, do you guys then write a prescription for 3 months then, and then they don't get their medicine unless they come back?
Yeah, from a baseline, we wait for their labs to come back, but before we prescribe it, but yeah, it's 3 months.
The risk is you need to be doing the HIV screen every 3 months, because if they acquire HIV and then continue to take the PrEP, you're partially treating HIV, and so the HIV screen is the most important of all of them for them to come back for. That's why we don't give more than 90 days of immunization.
So I didn't go into the details of where you go, but we can certainly send that out. Better references there. One thing we wanted to point out is who's really, where we see the trends in HIV infection going, like from a national level, and then how that translates to Nebraska. We have quite a bit of disparity when you look at, who's a big portion of our HIV infected folks and how they relate to our total population. And you can see that African American and Hispanic populations they make up such a small portion. You could even drop down the line there. They make up such a small portion of our population here in Nebraska, but they're disproportionately affected for HIV. And so that tells us, and this is nationwide, but we need to be focusing on certain subgroups and making sure that they get the care that they need. That's not always easy, as we found, but moving along with that, you can see the STD rates here in Douglas County. This is a little bit old, it's from 2017, but I don't think they have an updated one. And the dark red areas are where the highest rates of chlamydia are, and usually where chlamydia goes, you're going to see HIV too sometimes, so you can make assumptions there, but they're affected in areas where both African American and Hispanic populations, some of them live, and so it's important to recognize that. And then PrEP providers here in Omaha, you'll see, and I don't know what to make of this honestly, but this is Omaha. Back when I gave a talk, we had an HIV talk last fall, and that's what. So PrEPlocator.org, it's at the bottom here. You might be able to see, is a good spot where you can direct people to find a PrEP provider throughout the U.S. And so you can just type in a zip code. It asks you for somebody that's insured or uninsured, and you can, it'll pop right up. But we have very little providers, as you'll see here in a minute. But this is today, and we were surprised that there was quite a bit more. Actually, 2 of these are us.
6 months.
And then there's CVS Quick Care, which I didn't know was providing PrEP, so I'm not sure if that's a thing or not, but there's about 3 or 4 of them. But either way you look at it, it's good to see more plus signs up there. You compare our population with coastal cities that are about the same. It's not quite the same, but Miami and Oakland, you can see there's like tons of plus signs. So we're a little behind the 8 ball in the Midwest. I think there's a lot of factors that might play into that, but certainly there's a lot of room for improvement there. Another notion that what I found very interesting is at this CROI conference that we go to every year is these PrEP deserts. They call them PrEP deserts, and the left is people that are insured and the right is uninsured, and really it's just how far somebody has to travel to get PrEP. And it makes sense in the Midwest, you might have to travel a little bit further to a more metro area to get PrEP. But it certainly shows a huge disparity in the amount of access to PrEP care and getting it there. So how we've handled that, well, here anyway, so I run all the PrEP visits currently, and that's been a good thing in the clinic. We had a study that we just completed not too long ago where we tried to roll it out in a community pharmacy, and that went pretty well, but there's a lot of logistical challenges that are associated with that. And so we found, in our study anyway, we found that we're probably not hitting the right populations, but at least it was feasible and it was working. Other groups like Iowa, the state of Iowa has developed a telehealth program. It's also run by pharmacists as well, which is an interesting point. But it's been a good program. I know there's other states that have done it too, in Alabama and certain rural areas. And if you look at Trump's plan, it highlights some of the hot pockets are in rural areas. So it makes sense that we need to be focusing on other areas than we just think of right now. All right, so there's a few other concepts before we get to these cases we developed. So I'm going to let Sarah tackle those, and then we'll talk about those.
So I'll talk about some of the concerns that we've heard from providers where they're hesitant to provide PrEP, and then would be love to hear from you guys about any concerns that you may have, maybe that we can answer as well. And so the first concern is it safe? The next is, will it lead to resistance? And the last is, will it lead to riskier behavior if I prescribe PrEP? And so we have some answers for each of those at least. So the first is it safe? And I want you to walk away saying, yes, it's safe. So tenofovir and emtricitabine, or Truvada, are not like the antiretrovirals that you learned about in medical school and in pharmacy school, or wherever, where you are memorizing lactic acidosis and mitochondrial toxicity and all those scary drug interactions. These are newer generation nucleoside reverse transcriptase inhibitors that are really very safe and void of drug-drug interactions. And so the most common thing that patients experience is just what we call the startup syndrome, where the first couple weeks of therapy they have mostly just GI upset, so nausea, vomiting, some dizziness, and they usually wear off within the first couple weeks, and then patients are fine. The two other potential toxicities are mostly related to the tenofovir component, and they're renal and bone, but we see them very infrequently. And so there is some renal toxicity with tenofovir. It can cause tubular toxicity and rise in creatinine, but we saw very, very minor elevations in all the PrEP studies. And just something to be concerned about is a patient requesting PrEP or who would be a candidate for PrEP has baseline renal insufficiency. This is a toxicity that you want to be thinking about, but generally we don't see a lot of renal toxicity. The other is bone safety. So tenofovir also can cause a small decrease in bone mineral density, but it's associated with just a 1% loss, and that goes back to normal with cessation of the tenofovir. So again, overall very safe. Resistance is a really valid concern because remember we talked about it's a partial treatment of an antiretroviral regimen, but it's been really rare in the clinical trials. And so there was an analysis looking at, in one of the big PrEP trials, looking at the patients who acquired HIV while on PrEP, and none of them actually had resistance. What that means is that they were not taking the Truvada sufficiently to protect them from HIV, and so they also weren't taking enough to develop resistance. So resistance is really rare and not something to be concerned about unless they're not coming in for their HIV test and then are taking it after acquiring HIV. Okay. And then risk compensation. So this is something that gets cited as a real barrier for providers in prescribing PrEP, and I think it's a real valid concern. So this is the idea that PrEP use will lead to an increase in high-risk activities because of the perceived protection that the PrEP confers. And the concerns really aren't unfounded. So PrEP doesn't protect, the only thing it protects against is HIV. It doesn't protect against other STIs. And when we've looked at groups of patients, so Kaiser, for example, has a really large cohort of patients who initiated PrEP, and they found that about half, or 42% of the patients in their system within 1 year of initiating PrEP had a sexually transmitted infection. And so we're seeing high rates of STIs. What we don't know is how much of these high rates of STIs are attributable to the change in behaviors or increased condomless sex, and how much are attributable to this is already a high-risk population who's now being screened, right? And so to counter that, we have found that the higher risk, or the PrEP has not led to higher rates of HIV acquisition. It also, we also have found that the routine visits that we have with all our PrEP patients means that we're detecting the sexually transmitted infections and treating them. And what I found really interesting is that a recent modeling study, which we always have to think a little bit about how much to take those, really apply those to our practice, but a modeling study found that if we continue to enroll patients in PrEP and screen them frequently, we'll actually eventually see a decrease in the rates of STIs because we're treating asymptomatic patients and preventing further transmissions. So. Questions about those three? Yeah.
Who's indicated? What's the indication to use this? Who's the risk patient? Is there
Sure.
a good description of that person that I should be looking for?
Yeah, so I think it comes back to asking the patients about, so a lot of times we're not getting good sexual histories and asking about IV drug use, but it goes back to the long list of indications that the CDC has, but anyone who's engaging in condomless sex, anyone who has multiple partners, anyone who has a prior sexually transmitted infection.
So any of these things, not a multiple thing.
Yeah, no, any one of those means that they're also at risk for HIV. Yeah, but I think one of the biggest things is there's that long list, but for me, if patients aren't always comfortable sharing their risks or their practices and behaviors, and so if a patient comes to us asking for PrEP, that's honestly enough for me, and we get a good history and we say, well, they don't really seem to be at high risk, it's still enough for me to say, I'm at least going to consider it and talk to the patients about the risks and benefits, because there may be something that they're not sharing with us, but they're still at risk for HIV. So, yeah. Anyone else have other experiences? Yeah.
What's the prevalence in Nebraska? Like just in general.
HIV prevalence?
Yeah.
Yeah, and so we're a low prevalence state generally. Yet we see about, in this state, we see about 80 new infections every year. So, yeah.
80?
Yeah. Within our clinic alone, we see
That we know of.
yeah, but there are a lot who are on, I mean, there's still that cascade of care where there's still large, the first step is just getting patients diagnosed, and so most of the infections are coming from people who don't know they're infected, or from people who know that they're infected but they're not engaged in HIV care, and so but a low prevalence state that's still high enough to be screening and taking care of.
Yeah, the other, not to
Yeah, go
jump
ahead.
in. So the CDC throws out these like super impressive stats about different subgroups, and one of them that I just can't ever get past is an African American gay man, and 1 in every 2 will have HIV in their lifetime. I mean, that if that doesn't tell you anything, that's a lot. I think Hispanic men is like 1 in every 4 or something like that.
Yeah. That's their lifetime risk of
Yeah.
acquiring HIV. And so the hard thing is that most of the patients who are coming to our clinic for PrEP are sort of the overly educated white men, I would say. So we're still not reaching the young black men. We're not reaching
There's a lot of
a lot
cultural,
of women, transgender patients.
cultural barriers.
Yeah.
You know, they don't. It's this is my opinion, but I think there's, certainly reasons why they're not disclosing a lot of their practices.
Well, I find it interesting that they have PrEP on the TV. I don't think it's like a lot of the patients there are probably at risk of not going to be watching whatever.
Yeah. It'll be on Netflix.
Yeah.
They don't watch the doctors.
Actually, what's interesting too is that the company that makes Truvada and that didn't market it for the first couple of years. It's only recently that they've started marketing it. And part of some concerns are that we're not really reaching the right target groups with the marketing. And so lots of nonprofit groups and other healthcare organizations and even some cities have really organized their own campaigns to reach the at-risk patients.
And I worry that you're going to have a bunch of highly educated college students that are going to be like, dude, I need to go on this medicine because I'm going to have sex with lots of people, right? I mean, I don't know if maybe that's their scheme or their not really treat the population.
So we prepared a few cases that we thought we could go through and just talk a little bit about some scenarios that come up. But if you guys have cases or scenarios that have come up for you that you wanted to ask about, we can talk about those first. Yeah.
So I have a question. So what do you do about the, so as I work at Methodist and we have like a sexual assault team.
Yeah.
You know, unfortunately, we admit more patients than we want to admit underneath this protocol. So what do you do about these people? I mean, you got some random person, you have no idea what's going on with them. Is this somebody that you say, hey, you should probably get some, even though you have no idea, but I mean, do you offer this to them?
Yeah, so that would be post-exposure prophylaxis, which is a little bit different.
Sure.
But still really good to talk about. So post-exposure prophylaxis, the difference between that and pre-exposure prophylaxis is that post-exposure prophylaxis is actually 2 drugs, or 3 drugs, 2 pills. And so it's usually Truvada, which is what we use for PrEP, plus another medication. But yeah, so deciding who is a candidate for PEP, if it's an unknown, if you don't know, right, we don't know anything about who they were exposed to, but they had a true exposure, that is a case where we'll offer what we call sort of non-occupational post-exposure prophylaxis, absolutely, and it's something we frequently do. And for patients who receive that, if it's a one-time event, they may not be a candidate for PrEP moving forward after they complete their post-exposure prophylaxis, but if it's somebody who continues to be at risk, that's oftentimes where we start the conversation of, are they also a candidate for PrEP? Yeah.
Correct me if I thought the same nurses at Methodist do offer post-exposure, and then they follow up at the clinic.
And usually they will follow up, yeah, so like at least at UNMC, they get 72 hours worth of medication, and they follow up at our clinic, and then we provide them, they need a full 30 days worth of post-exposure prophylaxis.
That's
I
a
think
tough,
it's similar.
Yeah,
But
that's
then
a
you
really.
can kick them back to their primary care to get the conversation started.
Yeah.
If they have.
Yeah, that's a tough one because our experience has been a lot of them don't follow
Never
back
come
up,
back. Yeah.
and for whatever reason, those are perfect continuations.
To the individual that maybe misses 1 or 2 appointments a year on average, do you just tell them that they're not candidates for PrEP?
No, I mean,
I find that difficult to say, hey, you're still at risk, but you
Right.
miss a couple appointments.
Yeah, what's your threshold for saying like you're gonna be more at risk for?
yeah.
So that's
It's case by case.
yeah, that's a great question, and one I don't have a great answer for, but you could probably say it differently. But the way I handle it is a lot of times I just need a little bridge to get them by. But people, like I said earlier, they just fall in and out of care. They move all over the place and come back, and that's just been my experience. So.
Is there any
I think as long as they come back and get the HIV test and come back for the labs at that time, I'm willing to provide the prescription again. Because if they came back, it means that they're going to be at ongoing risk. The other issue, and we'll get to this a little bit, is that we prescribe it and tell patients to take it every single day to confer protection. but that's not always how patients are taking it. And so maybe it's lasting longer for them because they're not taking it daily. They're taking it more around the times of their exposures.
So is there significant evidence of harm to say that if they say, hey, I'm only coming back every 6 months, or if they travel a lot, to say that hey, their risk of benefits is outweighed by their risk of harm of developing hepatitis from, what's the risk of that?
Is that what some of your patients are, they're just traveling so they can't get back?
Well, no, sometimes they just don't show up for an appointment either, and I think it's kind of tough, I think from my standpoint, from an ethical standpoint, to say, hey, you need to come in and do this, just like would anybody with blood pressure medicine would say, if they were at their diabetes meds and say, hey, I know your blood sugars are probably still in the 300s, but no, you can't get insulin.
Well, I can tell you we would just call the pharmacy and get their refill history and see if they're filling it.
Well,
If they are,
yeah,
right. And if they are, then I don't think an extension would be a bad thing. What we've done in the past is, especially those that are traveling in from other places, I've seen people every 6 months. I don't like it, but I've done it. I just have them do an HIV test at 3 months, wherever their local health department is, and have them send it in.
You know, something the biggest risk is acquiring HIV.
Right.
You have a point of care test, so if you actually come and see you, and they have been for a while, say, HIV test. So what, and I can't remember what you said the window was for the fourth generation point of care.
Yeah, it's a good thing to talk about too. So remember, the fourth generation tests now include that P24 antigen, which appears earlier than the antibody, which older tests used to be antibody based, but it still takes a couple weeks for the P24 antigen to appear, and so there's still a window period from when they could have been exposed to when you can actually detect the HIV. And so another screening question that we ask patients before providing the prescription is, we do the point of care test, but we also ask them if they've had any symptoms of acute HIV within the last 2 weeks, to ensure that you're not at risk for starting someone when they're acutely infected with HIV but not yet laboratory test positive.
Would you start them on post-exposure?
So if they told us that they had symptoms of acute HIV, which are just like mono, fever, lymphadenopathy, rash, we would test them with a viral load.
I would just do an RNA.
Yeah.
So you brought up a question that like I can see my patients asking, and that like, well, what if I only took it like, for a week or two after I travel to Vegas?
Yeah.
I mean, I don't know,
Yeah.
but like, what would I, other than saying like, no, you need to take your medicine every day, like, how could I really counsel them and say like, yeah.
It's a perfect question, and we have a case that was a perfect lead-in. So we have a case where we're going to talk about exactly that. So we'll do this first case quickly, and then we'll get to the next case, which we'll talk a little bit about that. So this is a 28-year-old transgender female who comes in for her initial primary care visit. She tells you she's in a relationship with a man who has HIV, but that her partner is on antiretrovirals and undetectable. So now it's your turn to counsel her on her HIV risk. And what do you tell her? So you can pick something on this list, or you can tell me something completely different. The first is you tell her that condoms are needed to fully protect her from HIV. The condoms are only needed if she's bottom or the receptive partner. If no condoms are needed with any sexual activity, or PrEP and condoms are needed to prevent HIV. What do you guys think?
All right. The last one.
So last one, PrEP and condoms. Okay. Anyone disagree with that?
You know, there's the U equals U theory.
Yes.
So if she's got a lot of confidence that her partner's taking pretty regularly.
So that Dr. Bittner just brought up U equals U. Who here has heard of U equals U? We have some waving in the back. All right, I'm so glad, because this is a relatively new in the world of HIV, and it's something that we are sharing more and more with our patients and eager to share with all of you. And it's the concept that undetectable equals untransmittable. And so we now have really good data from randomized controlled trials and from long-term observational trials of partners who are serodiscordant, so where one has HIV and the other does not, and they're engaging in condomless sex, and there are 0 HIV transmissions. And so we can confidently tell our patients that even if they're in a relationship with somebody who has HIV, so long as the partner with HIV is on therapy with an undetectable viral load, meaning an HIV RNA less than 50, they are not at risk for HIV from sexual transmission. And so this is, even though this is an indication on the CDC PrEP guidelines that you can prescribe somebody PrEP if their partner has HIV, it's something that we have a real conversation with the patient about, because PrEP is not without any risk, and they may not be at real risk for HIV if their partner is on therapy and undetectable. Now in reality, what happens is a lot of times that the partner of the patient with HIV will tell me, I know they're undetectable and I know my risk is really small, but I don't know when he or she is going to stop taking their antiretrovirals, and it only takes a week or two from when you stop taking your antiretrovirals to when you have viral rebound. And so if that's the case and the patient understands that they're at low risk but they still want to be protected, we will prescribe PrEP, but it's not somebody who's at high risk for HIV.
Sorry, I'm going
Yeah.
on this. U
Yeah.
equals U, but what about fetal maternal
So really good question. So,
transmission?
yes. So, I mean, one of the reasons that we give all pregnant women with HIV, they have an indication for antiretroviral therapy, is because if they are undetectable, the risk of transmission to the fetus is negligible. But what we don't know, where we can't apply U equals U to is population. So this is only sexual transmission. So it doesn't include breastfeeding. So we still, our women, our female patients with HIV who deliver and then want to breastfeed, we still, even if they're undetectable, it's not something we still can allow, because there's still a risk of transmission that way. And also
Because
IV
it's
drug
unstudied, or because
there are
there
reports.
is higher? Okay.
There are reports of, yeah. And then IV drug use as well. So if you're sharing needles, they're not necessarily protected. Yeah.
So I'm gonna take the breastfeeding. And then what about as PrEP for breastfeeding? Because you pull it up on like Lactamed,
Yeah.
which is the Bible. It's big X, but it's indicated, but that's under the HIV, like, treatment
Oh, that's a good question.
indication. So, but I mean, if you look at like
Yeah.
the percent excreted in breast milk is pretty minimal.
Yeah.
So it actually probably prefer to prophylax the mom,
Yeah.
right?
Yeah, I think that would be a case-by-case scenario as well. So if the mom is at ongoing high risk for HIV but breastfeeding her baby,
We get bigger
all
problems,
of our women with HIV who have, yeah, that's a good question. It's safe in utero, so it theoretically should translate as well. But it will come
Because
up as a
when you
risk.
read it, it basically is just based on the HIV indication, but it's not based on.
Yeah. That's a good one. Yeah, what would you say?
I think it would depend on the mother,
Yeah.
honestly, and how much risk there is there. I mean, it is negligible, but it is TDF, or tenofovir form is not good, and I'm not sure I'd want my kid to have that.
Yeah.
But there's no good answer. Yeah, so 0 transmissions in all those people. All right, so case 2 actually something that came across my desk last week. So this is a 52-year-old guy. He's a gay man, and he'd been on PrEP for a while. Has some risk there with 5 partners the last 3 months. Doesn't use condoms all the time. Has no acute viral symptoms or STI symptoms, but his creatinine is kind of climbing up over time. You can see the bottom box there, and I think these are actual numbers if I remember right. So they're going up. He's still clearing. Actually, I think it was a little bit higher than that. He's clearing. The true calculated clearance for this guy was like 68 or something like that. So PrEP is a cutoff of 60 for creatinine clearance, so you got to calculate that. So the question is, what do you do with this person? He also had some chlamydia too, so he's at risk a little bit. So what would you do? Would you take him off PrEP? Would you tell him to take it less often? Would you work up his kidneys? Do from to us? Change his medicine? What would happen in takers?
What did you say was GFR?
60 or clearance?
I put 50, so that makes it a little more compelling.
Yeah.
Refer him.
Was that
Refer him.
refer him? Okay. That's what happened.
Just look at his renal. Yeah.
You can do it. You
Don't
can
take
multiple.
ibuprofen and you're good.
Yeah. Get a better history.
So that's what we would do. That's what we did. His creatinine went down. It was fine. But there are other options. So let's say his creatinine does stay elevated. Over time, maybe his clearance keeps continuing going down, and his creatinine goes up. What do you do? So one thing we alluded to earlier is this concept of OnDemand Prep. One of the studies, it's called the Hypergate study. It was in France, and the process of this study was to just keep it event-driven, and in hopes of reducing your exposure to the medicine and reduce your toxicity, but still provide protection. So what they did was they gave a double dose 2 to 24 hours before the first sexual encounter, and then 1 dose the next 2 days. So they got 4 doses over 3 days. The population was what they categorized as high risk MSM. I think they greater than 5 partners in like a week or something like that. So it was quite a bit of risk. So this is an option, I think, and what I didn't put on here is how effective it is. It's 86%, so it's pretty good. That was versus placebo. So they stopped the study early and changed everybody because of that. So they saw some benefit. My problem with it is the timing. If somebody it's not for everybody, I don't think. And so, for the right people, it might be a good fit. Now we have the people that I know anyway. We have maybe a handful that I know of that are using it this way. What I hear is it's more prevalent on the on the coast. A lot of people are using it that way, but right now I don't see it.
Yeah, and even though it's shown to be as effective as traditional daily PrEP, it hasn't yet reached the guidelines to recommend prescribing on-demand PrEP. So people are prescribing it off-label in this way, and especially in patients who are at really just have periods of risk, isolated periods of risk, and maybe at higher risk for toxicity because of older age or baseline renal insufficiency, or if you have a real reason to not want to give them daily PrEP.
I guess the other thing you wonder about, off-label at this point is, supposedly the reason for the renal toxicity is the no production.
That's the next slide.
Okay.
Yeah. No, you're good. It's perfect.
Oh, I did put it in there. All right, so the Discover trials, which was just released in March, but there's a newer form of the tenofovir portion, we call it TAF. It has less risk for the bone and kidney toxicity, and so the question was, is it as effective as the TDF form that's in PrEP? And so I didn't put all the slides on here, but basically it's non-inferior to what we know of as PrEP. It's an NDA is already out to the FDA for approval. So I think my personal opinion is the face of PrEP will change over the next few years, and what we know of it now, there might be numerous formulations beyond just this, honestly. But there were some infections, I think, or some seroconversions. What I would say about that is that the rates in both arms were significantly less than what the rate is just in the general population in the U.S. So we know that they work really well. And one thing I didn't put in here is the rates of STIs, which is huge. I mean, we know based on those rates that people were putting themselves at risk for HIV. So it's a good drug. This medicine, you can drop your clearance down to 30 for kidney function. So it doesn't totally eliminate any of those impacts, and if you have somebody that has additional risk factors for kidney dysfunction, you got to consider that. But this is what we did for that gentleman that I talked to last week. We put him on this, and he'll be fine.
It's a smaller pill too. 'Cause
Yeah, people like that. It's made by the same company. The interesting thing about that is a generic for Truvada will come out probably about the same time, which will make the payer landscape a little interesting. So it'll be interesting to see how that goes. Yeah. So if you look at, I just wanted to show this real quick, and I won't talk, but the people that seroconverted, they were either what we think probably infected before they were started, so acute infection was not totally ruled out, or they had low levels of drug in their bloodstream, so they just weren't taking it. And so you can see here, there's a little bit of resistance that showed up on the PrEP side, but it wasn't really enough people to really make a prediction on whether that would be different in each arm.
Is there any difference in the pharmacokinetics in terms of, I'm thinking about, you have a person who's not totally adherent taking TDF versus TAP, which is more forgiving?
Yeah, I don't want to get into all of this, but yes, there is. So one concept with the two different forms of tenofovir is tissue protection, and I think that might be what you're alluding to. But the tissue penetration of the TDF form, or what's in Truvada, is really good, and the plasma concentration is a little bit different too. So when you look at the TAF form, there's different PK characteristics in that, and so we thought that there might be some impacts on effectiveness based on that. But I would say, personally, in my opinion, is this study pretty much rules out that they're pretty well equal.
You don't think it's pharmacokinetic difference?
I know.
It's just cell versus plasma, intracellular versus plasma. But
So it's not the big factors, are you taking it?
yes.
All right, so this is another case that we had. So this guy came in to start PrEP. He was 48, another gay man, but he had some. He had been in the hospital and had what we thought was kind of resembled maybe acute viral symptoms, and it was kind of a muddy picture. But his HIV test, his point of care test, came back positive for the antibody, and a little like faintly positive for the antigen, which is kind of interesting. He had he just looked a little sick to me personally, so we were worried about that. So the question is, what do you do with this guy? Do you just consider him HIV positive? Do you start him on HIV treatment and get ahead of the game by trying to treat him early? Do you confirmatory test him, with the standard confirmatory test, and then get an HIV viral load as well before you do anything? You start him on PrEP, or do you have him come back for a point of care test in 4 weeks to make sure it's accurate? You kind of answered this one. Right?
Yeah.
Anybody?
3.
Yeah. So we do 3.
And this is the one time where you don't want to start PrEP without confirming.
I personally, I would almost consider number 2, maybe, but I would still get 3 as well. But 3, so the backstory that I didn't say is what his risk level was. Is really high. So the impression I got was that the risk for HIV could be like greatly there. But number 3 is the correct answer, and I think it's important to know that the viral load doesn't show up till about day 7 to 10. So you do have a gap there even before you'll even see anything. So there's about a 7 to 10 day window where they might have HIV, but you won't really pick it up on anything. So that's a tough window. All right, so I'm not going to get into this really. It's really what to do with false positives. Do you consider it a test or not, and all that sort of thing. It's a little beyond this topic.
I think we can skip the last case because it's already 8 o'clock, but I'll just go to the end. Well, yeah, so we just want to summarize by saying that PrEP works. We want you to think of it as something that's easy to incorporate into your practices, and just remember to think about it Remember, there are still some challenges with implementation, but you guys can all really help us, and there are many opportunities to do so. I like this picture because this is one of the campaigns that a group in Chicago is using to really just promote positive campaigning against for PrEP. And I like this one too. So we really can end the AIDS with all of your help. Yeah.
When does Truvada's patent end?
It's about a year and a half,
Oh.
maybe less than.
And now the company has a newer generation, so they're not too worried about that.
They've assigned a generic manufacturer already, so they like a primary manufacturer. So it might come sooner, I guess, is what I'm trying to say.
And I'll just share with you, if you guys ever, we're always available if you've seen somebody in clinic and want to call us and just have a question about PrEP or in the hospital. But also there's this great hotline called the PrEP line from UCSF that you can call anytime Monday through Friday between 9 a.m. and 9 p.m. here. And they have experts from UCSF helping with any PrEP questions too. So I've called them once or twice actually with questions myself. So lots of resources out there.
Practical question, if we've got a new diagnosis, what's the best way to get them to you?
Oh, good question.
Yeah, they need you.
Call us. Yep.
Okay.
Yep. And we have a couple of different, we have some social workers who do triage. We have, what? Yeah. Oh, actually, so, I mean, we would like to be called sooner rather than later too. There's more and more data to support rapid initiation of antiretrovirals. So really even starting treatment on the same day as your diagnosis. There's data to suggest that patients will suppress quicker and even remain in care. And so, yeah, call us and we'll do our best to get them in quickly.
So maybe I can get help from the audience on this one too. As a hospitalist, what do you think that our role is in this whole PrEP process? How do we be the most helpful? Because I don't know if it would be something I'd be starting in the hospital.
Yeah, sure.
Or should I? But it sounds like you need to have that ongoing follow-up.
Yeah, and maybe the hospital doesn't have to be the place where you started, but if you at least have the discussion and can provide the patient with resources for where in the area to get PrEP, that's huge. And so there are many different areas besides our clinic. I know you guys can mention if you're prescribing PrEP and want to offer up your resources, but even for uninsured patients, the NOAA clinic, the North Omaha Area Health Clinic, is offering PrEP. And so
veterans can come to the VA.
Veterans can come to the VA, yeah.
I would say if you've got, if you pick up on a risk that maybe we don't see outpatient, let us know.
Yeah.
I mean, just give us a holler.
Yeah. Especially anyone that comes in to the hospital with an STI, too. That's somebody to be.
IV drug use.
Yeah, that might fall way down on the bottom, but.
Anything else? Anne, you have anything you want to?
No, just this is the forms. The lighting isn't here, isn't the best. But if you could fill out those forms with your first initials of your first name and the first initials of your last name and the last four of your social, I believe. And then just what category you fit in as far as provider. And then there's also a very quick evaluation form. Was this worth your time? And then if there's any other topics you would like to have. That the AIDS Education Training Center could provide, or if you would like somebody to come to your clinic and do this talk, or to talk to your staff, or other issues that you have.
No, we appreciate you guys coming and asking such great questions.
Let's thank Sarah, Dr. Baird, and all your time and effort. There is dessert, and I'm sure it's going to be good because I think that thing is awesome presentation.
You guys ready for dinner? Should I do dinner? Yeah. Great. And dessert also?
Final kind of comments here. We're supposed to go till 9, so if you guys want to hang out.